Rahim. On behalf of Parsa HealthNet Eco Pakistan, I welcome all of you to this extraordinary and a historic session in collaboration with ACP and iHeart. So we'll just be starting in a minute. I'm just waiting for a few more people to join. I'll just take a minute. My name is Dr. Asad Chaudhary, and I'm Director of Parsa HealthNet Eco Pakistan. Our worthy speaker today is Professor Adeel, and he has also joined. I will just give you a brief overview of our collaboration, and then without wasting any time, we will be going to Professor Adeel for his talk, and then we'll take question and answers as always. So we just finished a meeting with Project Echo. Actually, it was from 9 to 10. It's still going on. I actually excused out of the meeting. So just in a couple of minutes, we will start. Okay. Today's session is COVID-19, what to and what not to prescribe. And our panelists today will be Professor Altaf Alam, Professor Javed Iqbal Faruqi, and Professor Zishan Ali. And all of them need no introduction. They are, in fact, pretty household names for our ECHO program. So before I invite Professor Adeel, I just share a very brief presentation with you, and then we'll go to Professor Adeel. So as I mentioned, it's a historic occasion, and inshallah, we look forward to a very healthy partnership between our ECHO program, iHeart, which stands for Innovations in Healthcare Advocacy, Research and Training, and American College of Physicians. A couple of lines on Parsa HealthNet Eco Pakistan. We had our immersion training and signing of contract in September 2017. And our first Eco clinic was in November. And we have around 205 health centers registered with us, and registered participants are above 1,500. And our running programs have been hepatitis, liver cirrhosis, advanced endoscopy, palliative care, and COVID-19. And if any of your institution wants ECHO training, I'll request you can contact me, and I can we can get you ECHO, and we can get you set up your own hub in Pakistan. Professor Adeel doesn't need an introduction, but it's a pleasure to introduce him. He's the president and CEO of iHeart Washington, which is dedicated to improving the delivery of healthcare to all patients across the globe. He's also professor of medicine and professor of population health sciences at Weill Cornell Medical College, New York and Qatar. Professor Butt is a Fulbright scholar, a Yale Johnson and Johnson scholar in international health, a National Talent Pool scholar, IDSA training faculty scholar, and recipient of many other national and international awards. He has delivered over 500 invited lectures globally, has published over 175 papers in high-impact medical journals, presented over 170 abstracts at major international conferences, and has mentored numerous young physicians and researchers who now hold key positions in academia in the United States. And I'm really proud to be one of his students, and he's been mentor to me also. Professor Butt served as a consultant for WHO and was co-author of WHO guidelines for the management of MERS-CoV infection. American College of Physicians, who with pleasure endorsed our program. It was established in 1915 and has 163,000 members in countries across the globe. It's a diverse global community of internists, internal medicine subspecialties, residents and fellows in training, and medical students united by a commitment to excellence. Through their voice, ACP creates a better place for internists, the profession, and their patients. The ACP medical education spans a wide range of content, which includes annals of internal medicine, medical knowledge, self-assessment program, ethics manual and ethics case studies, high-value care cases, physician well-being, point-of-care ultrasound, online learning center, and COVID-19 and ACP physicians guide and resources. This webinar is a particularly important milestone for medical education in Pakistan, and it is the first such program to be endorsed by the American College of Physicians in Pakistan or Asia, and we are really proud of this achievement. The partnership between iHeart and ACP emphasizes the tremendous importance to both iHeart and ACP place on high quality educational programs for physicians. The endorsement of ACP is also a testament to the very high caliber of educational and training programs iHeart delivers across the globe, with a particular emphasis on Pakistan. We have one program on 26th of July by Professor Bilal Hamid, which is not in collaboration with ACP, but that will be on Sunday. And our World Hepatitis Day Symposium for Primary Care Physician, again, will be, the speakers will be Professor Adeel Butt, speaking on redefining natural history and outcomes in the DAA area, and democratizing access to hepatitis C treatment, role of community doctors in HCV elimination by Professor Sanjeev Arora. So it's not to be missed. It's on July 29, 2020. It will be at the same time as today. So our today's talk by Professor Adeel Butt is COVID-19, what to and what not to prescribe. Thank you very much for your patient listening. Without wasting any time, I'll go to Professor Adeel. Yes, Professor Adeel Butt, it's over to you. You can start your presentation. Sir, you are muted, Dr. Adeel.
Okay, can you hear me now and see my slides, Asad?
Yes, we can hear you and see your slides also. Thank you.
Wonderful. So, first of all, I would like to thank all the participants who have joined. And I know this is a very, very busy season in terms of webinars, and there are sometimes 2 to 3 webinars happening every day. And even today, this is the 3rd webinar for several people who are in this call. So my hat goes off to all of you who have this tremendous hunger to learn and to share your own knowledge with us as well. I would like to thank Asad and his team, who are such an amazing team of people who have done so much for the cause of medical education in Pakistan over the last several months and several years or so. And their partners, Parsa, HealthNet Echo, which is the platform for this talk. And my gratitude also to American College of Physicians for endorsing this talk, which is the first for Pakistan for this sort of webinars. So before I start, I declare that I have no disclosures related to this talk. And the objectives of this talk are relatively simple. I will start off with the diagnosis of SARS-CoV-2 infection and spend most of the next 30 to 40 minutes or so on reviewing the most recent papers on treatment of SARS-CoV-2 and COVID-19 infection. We will talk about pivotal clinical trials of pharmacologic agents, and then finish off with the non-pharmacological interventions, which are basically public health measures, and see if they are actually of any value. So just one slide about the situation report globally and for Pakistan. And I'm sure many of you follow this every day. As of a few hours ago, there have been more than 15 million cases reported of COVID-19 across the globe, with 620,000 plus deaths. In Pakistan, the number of cases exceeds 267,000, and the deaths are approaching 6,000. Now, as you can see from the curve on the right side of your screen, that both the number of cases as well as the number of deaths are showing a downward trend in Pakistan. This is a very, very good sign. Whether this is actual true sharp decline or a matter of reporting still needs to be verified and seen, but at least we are seeing a good sign of a decline in both number of cases as well as deaths. Before we go into the treatment, I think it's important to understand how to diagnose SARS-CoV-2. And the gold standard for that right now is nasopharyngeal swab. That is what we do most commonly, and it's the most clinically used specimen for the diagnosis. Now, lower respiratory secretions, particularly bronchoalveolar lavage fluid, is more sensitive than nasopharyngeal swab in diagnosis of COVID-19. However, we do not recommend that unless there is no other option to make the diagnosis. And the reason for that is that doing a BAL is a much more invasive procedure and also places the healthcare workers who are doing the procedure at a very high risk of acquiring infection. So unless there is another reason or there is no other way to diagnose, we do not recommend doing routine bronchoscopy on these people. The virus can also be found in stool, and now there are also rapid serologic tests that have been developed, which can give you an antibody test result in about 10 to 15 minutes or so. And there are tests being developed which can do that even quicker than that. Radiology, whether it's a chest X-ray or a CT scan of the chest, plays an important part in diagnosing COVID pneumonia. So it doesn't diagnose infection, but if you have infection diagnosed by PCR of the nasopharyngeal swab, it will tell you whether the patient has developed a pneumonia or a lower respiratory tract infection or not. And this is important to know because your treatment may be different if they actually have pneumonia. What is the sensitivity of various type of specimens? So nasal swabs or nasopharyngeal swabs, which are the ones that we do most commonly, have a sensitivity of about 63%, which is close to deep sputum, which is 72% or so. BL fluid or bronchoalveolar lavage fluid is positive in 93% of the cases, which is more sensitive than nasal swab, as I mentioned in the previous slide, but more difficult to do, more invasive, and also poses the risk of transmission of infection. The viral load in an infected patient does decay over a few days. So in about 7 to 12 days or so, viral load in respiratory secretion goes down sharply. However, what is important to note on the right hand of your slide is that in severe disease, patients who have severe disease may shed the virus for a longer period of time compared to patients who have milder disease. And that is why those with more severe clinical disease need to be monitored and kept in isolation for a slightly longer period of time. The tests are relatively sensitive now, and but the positivity of the test depends both on pre-test probability and the actual sensitivity of the test. So the more sensitive the test, as the green line shows, the threshold for having the pre-test probability goes up. In other words, you have more of a latitude in being able to diagnose the infection even when the pre-test probability is high or low. This study is an important study. It was published in New England Journal of Medicine a few weeks ago. This looked at patient-collected swab versus healthcare worker collected swabs. And it turns out if you teach the patient how to collect a tongue swab, nasal swab, or a mid-turbinate swab, they have very high level of sensitivity, which is quite comparable to those collected by healthcare workers. So the correlation or correlation between patient-collected and healthcare collected swab was 90 to 96% or so. So in selected settings where healthcare workers may not be easily available, to go and take the swabs. Patients can be taught to do that themselves and bring it to the testing center. Let's move on to treatment now. And the first thing I want to show is the first principle of medicine, which is do not do any harm to your patients. And I just did a scan of various types of totkas or unapproved therapies that have been going on the social media. All these have absolutely no role in treatment of COVID-19 infection. And actually, some of these may be harmful for the patients, particularly if patients do not seek proper medical care and just rely on these things. So try to avoid that. And as physicians, we have a responsibility to educate our patients and the public in pushing back against these unapproved therapies. To understand the therapeutic agents that are available and are in development, it is good to understand the life cycle of the virus. So the virus attaches to the cell's YAS2 receptors, and once internalized, it fuses with the membrane. And after membrane fusion, the virus, there's uncoating of the viral genomic material. This virus then is translated, divides, and is repackaged or reassembled, and then through exocytosis leaves the cells, the infected cell. And there are drugs or agents that have been either in trials, that are either in trials or are in early phases of development, which target various targets along this pathway. There are a lot of clinical trials ongoing, and this paper was published about a little over a month ago, looking at how many trials are being conducted by looking at the registered trials on a government website. They found close to 2,000 trials through a quick search. 834 of those were observational trials, but even after excluding all those observational trials and where details of the trials were not available, they found 674 active intervention COVID-19 clinical trials which were ongoing. Of these, the largest number was hydroxychloroquine and hydroxychloroquine and biologicals. And as we will talk about chloroquine and hydroxychloroquine, I think these trials should actually be stopped because they've been shown to have no benefit in patients. There are several trials with remdesivir, which actually has, the number would have increased by now. IL-6 and IL-1 blockers like tocilizumab and anakinra. There's several trials going on that, some on convalescent plasma, and a few on azithromycin and antibiotics as well. Now, this is kind of a summary slide, which I want to put right up in the front, and then we will go on to discuss some of the studies which provide evidence to this slide. So the drugs that have possible role in treatment of COVID-19 are remdesivir, corticosteroids, convalescent plasma or serum, and IL-1 or IL-6 blockers like tocilizumab or anakinra. Drugs that have an unclear role are colchicine, ivermectin, interferon ribavirin, non-steroidals, etc. Drugs that at this point have no role in treatment of COVID-19 are chloroquine and hydroxychloroquine, azithromycin, lopinavir, ritonavir, oseltamivir. What is the evidence to support these? So we will start with the drugs that have that have been shown to have no role. And this is the original hydroxychloroquine plus azithromycin study that started all this hype about this drug combination, and we are still paying the price for that poor science that was done and published and widely publicized. This was a study of only 20 patients, and there was no control group. Patients were of varying disease severity. It is unclear what other treatments they got. The time of infection was unclear, but somehow the investigators found that there was a significant reduction in the number of people who had cleared the virus after about 5 days or so. So in other words, they showed that hydroxychloroquine plus azithromycin combination significantly accelerated the removal of virus from the body. Subsequently, this study has been discredited significantly, but the same group then published a follow-up study in a small journal, and in this study, they recruited 80 patients, and these patients consisted of those with upper respiratory infection as well as lower respiratory tract infection. They gave them hydroxychloroquine and azithromycin, and their outcome measures were aggressive course of disease, which they measured just by looking at oxygen requirement and need for ICU admission, contagiousness of the virus, and they looked at PCR with the CT counts and length of stay in the infectious disease ward. There were several problems with this trial as well in terms of recruitment. First of all, this was a combination of upper and lower respiratory tract infection, about evenly distributed. But even those who had severe and those who had pneumonia, in other words, those who had an X-ray which showed unilateral or bilateral infiltrates, even those people had very low severity of disease. Overall, at the time of presentation, 92% had very mild disease. And this did not change significantly at the time of discharge. Over a period of time, they did show a decrease in contagiousness of the virus and some decrease in the length of stay in the ward. But again, there was no true control group in this study. The disease severity was variable, and even then it did not change over a period of time. And even patients who had pneumonia may have had very mild disease. So it was not really very helpful for us to judge whether this combination was helpful or not. Brazilian group did the study named Chlorocovid, and this is probably the only other study that showed some benefit of this combination. This study has not been peer reviewed. It's still in preprint servers. They looked at 81 patients, and they were on day 6, there were only 7 deaths in one group and 4 deaths in the other group. So the number was relatively small, and their treatment interventions were low dose and high dose chloroquine. They did demonstrate some benefit, survival advantage in people treated with chloroquine, but the number was relatively small and the criteria were not very clear. There was another French study, which was a larger study done at 4 French hospitals in patients who had developed pneumonia and required oxygen supplementation. And they had close to 200 patients. They did not find any reduction in death or transfer to ICU or day 7 mortality overall or occurrence of a respiratory distress syndrome or ARDS in hydroxychloroquine group. So they found no benefit of this combination. Much larger observational studies have since been done and published after thorough peer review. This study was published in New England Journal of Medicine, looked at 1,376 patients, and found that there was no significant association between hydroxychloroquine use and intubation or death in the main analysis. They looked at it several different ways in sensitivity analysis by matching the 2 groups, using inverse probability weighting, as well as propensity score weighting, and in any case, they did not find any benefit of hydroxychloroquine. Another study looking at hydroxychloroquine with or without azithromycin looked at close to 1,500 patients, and this study also did not find any significant benefit associated with treatment with either drug. There was some signal of actual harm caused by this combination. The patients who got hydroxychloroquine plus azithromycin, they had 213% increased risk of cardiac arrest compared with those who received neither drug. So the odds ratio of getting having a cardiac arrest in hospital was 2.13. So this actually not only showed no benefit, but showed significant harm being caused by hydroxychloroquine and azithromycin. Interestingly, when they looked at either drug alone, those drugs were not associated with increased risk when given individually. People also have asked us frequently about the role of hydroxychloroquine in post-exposure or even pre-exposure prophylaxis. So this was a randomized, double-blind, placebo-controlled trial of 821 subjects, again published in New England Journal of Medicine a couple of weeks ago, and they found no benefit of using hydroxychloroquine for post-exposure prophylaxis. So in other words, giving hydroxychloroquine was not associated with the low risk of developing COVID-19-like illness. So the final verdicts on hydroxychloroquine and azithromycin is that there is no role of these drugs in treatment of COVID-19. There's no role of these drugs in prophylaxis. In fact, there is a higher risk of cardiac arrhythmias and a likely high risk of sudden cardiac death and or overall mortality, so they should be avoided. Next drug, which initially was used in many protocols, was lopinavir-ritonavir, and it turns out that a relatively large study of about 200 patients, randomized trial, did not find any significant benefit of lopinavir-ritonavir compared with the standard of care treatment, neither in terms of clinical improvement nor in terms of reduction of viral load of SARS-CoV-2 in these patients. So again, no benefit of lopinavir-ritonavir. Now let's go on to a couple of few therapies that have shown promise. So, and let's start with remdesivir. So remdesivir, as some of you may remember, was initially used for Ebola virus, did not take off widely, but was also found to have activity against other viruses. And when SARS-CoV-2 came, it was found that it does have some activity against the virus, and then clinical trials started. So this study that was again published in New England Journal of Medicine in June last month was an open label compassionate use protocol of 53 patients, of which 57% were on mechanical ventilation and 8% were on ECMO. And this study showed that 10 days of remdesivir plus standard of care showed significant improvement in oxygen support class during the follow-up. However, this study did not have any control group, so it's difficult to understand or decipher if these patients would have gotten better anyway. When you go into the details of this study and you break the patients down by the oxygen status at baseline, it turns out those who did not require oxygen at baseline or only required non-invasive ventilation did very well regardless. So these patients probably would have done very well with or without treatment. But when you look at those who required invasive ventilation or mechanical ventilation, these are the people in which only half of them had improvement, and there were a significant number of people who had adverse outcomes. It's difficult to understand the results, but without a control group, but there was a signal that this does improve outcomes. Then the next trial looked at 5 days of remdesivir versus 10 days of remdesivir. This was a randomized open label phase 3 trial, and this included patients who had oxygen saturation of less than 94% at baseline and also had pneumonia on chest x-ray. Enrolled about 400 patients, and the outcome in this trial was 2-point improvement in clinical status, which was achieved in 64% of the patients in the 5-day group and 54% in the 10-day group. So in other words, 5 days of remdesivir was as good as 10 days of remdesivir. No need to give longer course of that. Again, when you break it down by oxygen support at the time of presentation or baseline, those who required invasive mechanical ventilation, the 5-day group had 40% mortality versus 10-day group, which had 17% mortality. The number was relatively small. Therefore, statistically, this was not significant, but numerically, there was significant difference. Those who required high flow of oxygen, the 5-day group had 10% mortality, and the 10-day group had 15% mortality. Those who required only low flow oxygen or no oxygen at all, they did very well regardless. Then this is the ACT-1 study, a large phase 3 adaptive randomized double-blind placebo-controlled multi-center global trial, which recruited about 1,000 or so patients, and remdesivir 200 milligrams loading dose followed by 100 milligrams daily versus placebo. And the primary outcome was time to recovery in these patients. And this study found that median time to recovery in patients who were on remdesivir was significantly shorter than the placebo group. So 11 days versus 15 days, and this was with a p-value of less than 0.001. The overall mortality was numerically lower in the remdesivir group. There was 7% deaths in remdesivir and almost 12% in the placebo group. Excuse me. This did not reach statistical significance because the number of deaths were relatively small in both groups. So for the first time, a drug has shown in a double-blind randomized placebo-controlled trial some benefit in clinical outcomes. Another study, which was a randomized double-blind placebo-controlled trial also looked at similar outcomes. However, this study did not find any significant improvement in clinical status of the patients. They did not find any reduction in viral load either. But I think the preponderance of evidence shows that remdesivir has benefit, which is appreciable after a few days of therapy with a 5-day course. Then another study which has generated a lot of interest recently is using corticosteroids or dexamethasone, or the Recovery Collaborative Group trial, which was done in the United Kingdom. This is a unique design, a controlled open label, but not truly randomized study. It used dexamethasone versus usual care. So this group enrolled thousands, close to 10,000 patients in a very rapid fashion, and they allowed various subgroups to be enrolled in the study overall. And they found that benefit of steroids was seen in the participants overall. In other words, those who received steroids had better overall survival. But when they broke it down by oxygen requirements, it turns out all the benefit was seen in patients who required oxygen. Those patients who had mild illness and did not require oxygen or only required low flow oxygen had no significant difference in their outcomes. So that point is important to remember, and I'll come back to that. Their primary outcome, which was mortality at 28 days, was a 17% improvement in mortality, a reduction in mortality in the steroid group. And in secondary outcomes, which included discharge from hospital, invasive mechanical ventilation, or death, the composite outcome was overall better as well in the steroid group. There are very few studies right now which are published using convalescent serum and plasma. This was one of the original studies using only 5 patients, which showed that plasma transfusion does have some benefit in these people. And then there was a more recent study, which is a single center experience in 138 patients who received convalescent plasma. And they found that this does have some clinical benefit in terms of reducing the time to clinical improvement. However, the benefit was noted mostly in people who got this convalescent plasma within 7 days of symptom onset. In other words, this has to be given very early on in the first week or so of symptom development to have significant benefit. And this is a table which shows the results from this trial. The composite outcome of highest severity achieved during hospitalization. In other words, severity of illness as a composite of these 4 factors was significantly better in patients who received convalescent plasma versus those who received standard of care. Other outcomes when taken together, which included discharge from hospital, death and hospitalization, were also better in those who received convalescent plasma versus standard of care. However, they did not look at these outcomes separately for us to understand which one is driving the whole equation. IL-6 and IL-1 blockers have also generated a lot of interest. This was one of the original studies of tocilizumab, which showed a rapid decline in inflammatory markers and clinical markers, including CRP, temperature, concentration of oxygen required, and oxygen saturation in patients receiving tocilizumab. More recently, trials have been reported on IL-1 receptor antagonist, which is anakinra. And this study is a matched cohort study of 96 patients, 56 in the anakinra group and 44 in the control group. And these are patients who had severe bilateral COVID pneumonia. Anakinra reduced both the need for invasive mechanical ventilation in the ICU as well as mortality among patients who had severe COVID-19, and it did not have any significant side effects. So you can see that compared with historical controls, it did much better in terms of reducing death or invasive mechanical ventilation or either. Another study looked at the same drug in patients with ARDS and hyperinflammation or cytokine storm, which is described or defined as a CRP of more than 100 and a ferritin of more than 900 nanograms per milliliter. This was a retrospective study, a small study in patients with moderate to severe ARDS, and showed that those who received anakinra had a better survival of 90% versus 56% survival in those receiving standard treatment with a significant p-value. However, mechanical ventilation-free survival, although better in the anakinra group, was not statistically significant compared with the control group. So again, this shows that in a specific subgroup of people who have hyperinflammation, IL-1 blockade is of use. Now moving on to some studies which have questionable benefit, or still trying to understand their role in treatment. So colchicine has been doing the rounds in social media. This was a proof of concept study, randomized open label clinical trial, and it enrolled 110 patients who were randomized, 54 people in the intervention group and 56 people in the other group. And this did show some improvement in time to clinical deterioration. In other words, those who received colchicine were less likely to progress in the clinical disease. However, there was no significant difference in inflammatory markers in the two groups. So there is a signal out here of some benefit, although it is too early to say how to use this, or if at all to use this. So I would suggest not jumping onto this till we have more data on this. Ivermectin initially received a fair amount of enthusiasm, but then I've not seen any clinical trials published on this drug after the first couple of reports, which showed a sharp reduction in virus in cell cultures at 48 hours. So I won't go into the details of this too much. So I tried to prepare a summary of therapeutic options for quick reference for those who want to look into this thing. And the 4 drugs that have been shown to have some benefits, I tabulated them according to 2 factors: what to give, who to give it to. In other words, which are the patients with COVID pneumonia, which subset of patients are likely to benefit from these drugs, and what can you expect in terms of improvement in their clinical status. So remdesivir should be given to people, or has been shown to improve outcomes, generally only in people who have pneumonia on chest X-ray or CT, those who have low oxygen saturation on room air and require supplemental oxygen, patients who are on mechanical ventilation, and generally people who have symptoms onset of less than 10-day duration. These are the people who generally benefit the most from remdesivir. Those who have no oxygen requirement or are doing generally well and are asymptomatic probably will not get any benefit, at least as far as we know at this point in time. What you can expect in terms of response in these patients with these criteria is a shorter time to recovery of 11 versus 15 days on average. There is probably some mortality benefit in the first 2 weeks or so, although this did not reach statistical significance, but looks promising in that regard as well. Steroids were also shown to have benefit in people who required supplemental oxygen or those who are on mechanical ventilation. Of significant importance, steroids had no benefit in people who either required low flow oxygen or required no oxygen at all. So if people have good saturation on room air and have mild to symptoms or no symptoms, you should not give steroids to those patients because they've not been shown to help. What you can expect is probably a mortality reduction of about 17% overall, but no benefit in those not requiring oxygen. The criteria for convalescent plasma are much less clear, but if you have to give this therapy, it should be given early on, within 7 days of symptom onset. And in terms of what to expect, perhaps early viral clearance and decreased severity of illness when given early. Similarly, with IL-1 and IL-6 blockers, generally people who benefit are those with severe bilateral pneumonia, those with moderate to severe ARDS, and those who have hyperinflammation or a cytokine storm. And here you can expect a survival difference or reduction from 90% mortality to about 90% survival versus 56% survival in patients who are treated with this drug. You can also perhaps see some mechanical ventilation-free survival, though this has not reached significant statistical significance in clinical trials. Let me round off the treatment with a couple of other associations, basically with ACE inhibitors and angiotensin receptor blockers. Since the virus uses the ACE receptors, it has been theorized that use of ACE inhibitors may have some effect on the clinical course of the disease. Two large trials have shown that there is no adverse effect of using either ACE inhibitors or angiotensin receptor blockers in these patients. This is the first trial which showed no difference, and this is another case population study of close to 1,200 patients versus 12,000 patients who were population controls. And these RAS inhibitors did not increase the risk of COVID severity or mortality related to COVID. So in other words, ACE inhibitors and ARBs can be used with a fair amount of certainty that they will not cause any harm. Let's finish this off with non-pharmacologic interventions or public health measures. Do these work? I think there is plenty of data which show that public health measures, including face masks, social distancing, and targeted lockdowns, have dramatic effect on controlling the epidemic or pandemic in countries. The countries who use that judiciously showed a decrease in number of cases and deaths very quickly within 2 to 4 weeks of concerted and coordinated measures, public health measures. We see a lot of anger in the public against wearing masks. And there is a segment of population who thinks that masks generally are not effective. But there are clinical data and study data that show that masks can actually reduce the transmission of infection significantly in general population. What is the efficacy of a mask and what is the evidence behind that? If you use regular surgical mask, you can reduce transmission of droplets more than 5 microns from 30% without mask to almost 0% if you're wearing mask. Aerosol particles which are less than 5 microns without mask, 40% a chance of transmission versus 0% when you're using a mask. So there is a significant reduction by using masks. So how do we prevent this pandemic? How do we address this? So of course, first thing is to prevent ourselves from getting infected. And then, God forbid, if we are infected, we should prevent, or if a patient is infected, we should prevent that person from transmitting it to the rest of the population. And these are the measures which I think you all know very well: social distancing, proper hygiene, stay at home, and no mass gathering, which need to be in place. Excuse me. We also need to think about workplace realignment, especially when now that many countries are trying to open up the economy and businesses. We need to put administrative controls, personnel controls, and engineering controls in our workplaces so that we prevent the transmission of infection. And these include having enough PPE, trying to keep people in social distance from each other, avoiding use of each other's phones or desk equipment, etc., helping with the ventilation, airflow, and making sure that the workplace surfaces are cleaned very regularly and thoroughly. So in summary, remdesivir, steroids, IL-1 and IL-6 blockers have shown promise in treatment of COVID-19 pneumonia. However, their benefit is seen only in certain specific subgroups of patients and should not be used. These drugs should not be used in everyone indiscriminately. Hydroxychloroquine and azithromycin combination has shown no benefit and actually has shown harm. So this should be avoided. We didn't talk about vaccines today because we are not close to any vaccine for clinical use. They're still many months away. So in absence of that, we use these drugs, the first 4 drugs that we talked about: remdesivir, steroids, convalescent plasma, IL-1 and 6 blockers. But beyond that, the best strategy currently is public health measures to prevent spread of infection. So this was a quick overview of the current status of therapy. I've tried to cover all the major trials that have been published. There are some other smaller studies which do not add anything significant on top of what I've shared with you. But I'll be happy to answer any questions at this point in time.
Thank you. Thank you very much, Adeel. Yet another excellent talk. without taking a lot of time, I would just like to have quick comments from the panelists. Uh, I like to request Professor Javed Iqbal Farooqi, who is joining from Peshawar and has been very keenly and actively following COVID for us in Pakistan. Ji Javed.
Yeah, thank you. Another great lecture, comprehensive one. वो जो कहते हैं ना कि समंदर को कुछ में बंद करना तो वो अदील भाई कर सकते हैं. What a
So
great
kind of
review.
you.
Yeah, it's very important that when we come to the clinical practice, all out of all those options, what has shown to be working is, of course, the remdesivir and the dexamethasone. These are the two drugs which helps, but not in each and every patient. They should be given judiciously in those who need it. Like remdesivir is given in those patients who have got severe disease, as Adeel Saab has said, those who are having the third degree severity. And dexamethasone is when the patient has developed the cytokine syndrome along with the IL-6 inhibitors. And mind it that these patients who need these drugs, they're only a fraction of that, probably not more than 5 to 10% if you take the remdesivir, the Daxa, as well as the IL-6 inhibitors. So one is that every patient doesn't need that. And second, if you need to start these drugs, they should be given well in time. We all know that the COVID is the 3 weeks acute viral disease. And what we see, the long term are in the 4th, 5th week. This is your immunological response to that. It's not the direct viral. So I wonder that people have given these patients the antivirals, remdesivir, or other drugs, even 4, 5, 6 weeks after they become infected. So these drugs should be given right in time and only in those patients who really need it. The convalescent plasma therapy, still it is an experimental one. And unfortunately, we've seen it's, being sold in lakhs here in Pakistan. This is the dilemma. One of my relative took the September for more than around 2 million and the patient died. So, this is the dilemma that when you are not using these drugs in proper patients at proper times, and everyone is after this happens. So once again, thank you very much, Adeel Bhai. We learned a lot. Every time we listen to you, we learn, our knowledge, our understanding improves. And I hope that with all these helps and with Almighty Allah, we overcome this disease, this crisis. And I hope that, as you said, our curve is hopes to be going down, and we hope that only a couple of months are left, inshallah, and we'll be out of this crisis. Thank you very much once again.
Thank you, sir. Thank you. I'll now go over to Zishan. Zishan is in JPMC Karachi, and he has been at the forefront of dealing with very sick COVID patient there. Zishan, we'd like to have your comments on the talk and the current scenario.
Thank you, Adeel and Asad, for organizing such an excellent program. And Adeel, as usual, have shown his excellence and his class, and reviewed the literature very effectively and very conclusively. And hats off to him for excellent presentation. And as far as the COVID management is concerned, I agree with Adeel's conclusion, what he displayed, that drugs are there now. We are much better off in terms of managing COVID, where we were 2 or 3 months back. But they have to be used judiciously. Now data is there to make a wise decision in which patient we should use what medication. And as far as the steroids are concerned, I agree what in our experience, the maximum benefit goes to those patients who need oxygen. If the person doesn't need oxygen, hopefully is very likely is going to come off. There was a question in the chat as well at the day 10 or 11 when the patients have got very high inflammatory markers, still doesn't need oxygen as per. yes, these may be few subset of the cases in which you may make a clinical decision to use steroids as an outpatient or home care patients, not for everyone. But at day 6 or 7 till day 12, in my experience, what I can say, if the inflammatory markers are high, even if the oxygen demand is not there, we do give steroids and we see less deterioration, less admissions in these patients. Though we are not doing COVID OPD regular, but we are managing the families of the patients who are admitted in the hospital. So overall, COVID is declining. 2 weeks back, we had more than 50% in our hospital. Today, we have got less than 25 patients, and only 3 are on vent. So the outcome of this disease, because of the knowledge about the managing the disease, has become better probably. I agree. One of the previous talk in Adeel did commented that is it the true mortality which we are talking about, because yes, many of the patients are not getting tested and they are not, their deaths have not been getting reported. So the data in Pakistan, what we talk about in that talk as well, in the other day we did talk about, for every one patient diagnosed, I would say 10 to 15 patients are behind which are undiagnosed. So it's not today there was a report from New York, the 1:10 with the antibody titers, they realized that 10 times higher incidence of the COVID, what they have already reported. So that remains underreported, but luckily we are getting less severe disease probably. And even in the hospital, deaths have gone down, admission rate have gone down, pressure for admission of HU care have gone down. So we are hoping that the peak is going through as a downward trend, and with this coming Eid festival and the Muharram, these are the risks of continued cases. Once after the Muharram, we might see real decline in the number of cases.
Thank you. Thank you, Zishan. I'll just request everybody to just follow the chat also, because a lot of questions have been answered by our faculty in the chat. Bushra, if you have some burning questions, we have a few minutes. Professor Adeel is here. So please quickly go around the questions.
Thank you, Dr. Asad. Dr. Adeel, there's a question on favipiravir. Can you tell us about the results in COVID-19 with favipiravir?
So favipiravir is undergoing clinical trials, so nothing major has been published that I would come across as of this morning. If you recall, this has been approved only in Japan so far, and perhaps one other country. I think Russians are also using that to some degree, but we haven't seen any significant clinical trial results to make it a recommendation to give it right now.
Right, thank you. Would you recommend testing PCR after every specific intervention, such as steroids or convalescent plasma or interleukin-6 inhibitors? Is it recommended or not?
No, so we should go by clinical course of the patient. I think that is very helpful, because PCR, most people would on this call would realize that PCR remains positive for a very long period of time in certain patients, and that is not actually a viable virus but viral fragments. So it is very difficult to differentiate that. We might be just chasing our tail by going after a positive PCR. Go by clinical symptoms, that is much more helpful.
Right, thank you. So there are two separate people have asked the same question, almost the same question, that if somebody has supposedly recovered symptomatically but is still shedding the virus, is that person still infectious to his relatives or people around him?
So the evidence we have thus far, if the patient is completely asymptomatic and more than 14 days after diagnosis or after the first symptoms appeared, the risk of transmitting infection is very, very low. So these people are generally probably shedding non-viable viral fragments, so the risk is very low. Now, no one can say with 100% certainty that such people will never transmit infection, but evidence shows that the risk is extremely low. We actually take out people out of isolation. We don't even do a second swab after 10 days of isolation or 11 or 14 days of isolation once the symptoms have resolved.
Thank you. Is there any possibility for anti-inhibitors in the treatment of COVID-19?
I'm sorry, anti what treatment?
Anti-TNF, TNF inhibitors.
The biologics that we've seen are only IL-1 and IL-6 blockers. So we haven't seen any trial on TNF blockers, at least I haven't. If other worthy panel members have seen something, please, I would love to learn about that. But I have not seen any TNF alpha trial so far.
Thank you. What about any further studies going on for convalescent plasma?
So in the slide that I showed about 600-700 clinical trials are going on, a couple of dozen studies on convalescent plasma are ongoing right now. 2 or 3 have been published, which I shared with you. Rest are still ongoing, and we should get the results relatively quickly.
Thank you, Dr. Adeel. Is there any role of Declatesvir and Ribavirin in the treatment of COVID-19?
What was the first one?
Declatesvir and Ribavirin.
Declatesvir and Ribavirin. Again, there is one paper or one review or one opinion that has been going on around, which is being shared by everyone, showing anti-Hep C drugs having some role in treatment of COVID-19. There is no randomized trial. There is no proper study looking at that. HCV virus is very different. HCV polymerases are different than coronavirus polymerases. So it is it is a stretch of imagination that specific polymerases against HCV polymerase would be effective against coronavirus polymerase. And again, I haven't seen any real study. Only 1 or 2 anecdotal reports are more like opinion pieces. But again, we have very senior people like Professor Altaf Alam, Professor Faruqi, Asad, and yourself and Zishan. If you have seen something else, I would love to learn about that.
Thank you, Dr. Asad. Dr. Asad, Dr. Adeel, can you highlight the role of anticoagulation and the dose that is used for heparin?
So anticoagulation came along when people started seeing this vasculitis and thrombotic events in people who are hospitalized, particularly those who are in the ICU. So generally we start off with the regular dose of fractionated or unfractionated heparin. But if you see thrombotic events, like significant deep vein thrombosis or others, then you can do full anticoagulation carefully in the ICU. But this is generally only in ICU patients. We haven't seen much otherwise. Very interestingly, I had a patient today, a young Kenyan guy from Kenya, about 28 years old, who came with bilateral pneumonia and chest X-ray infiltrate, so everything clearly showing that. And then one day into the hospital course, or actually 2 days into the hospital course, developed chest pain. And chest pain was very suggestive. Turned out he had 100% blockade of proximal LAD. A 28-year-old guy. But there's a twist. Because we do a lot of routine testing on a bunch of these patients. It turned out he was also HIV positive. So I don't know what gave him this thing, whether it was azithromycin that gave him a cardiac event, or COVID-19 or HIV, because all of them are associated with increased risk of cardiovascular events.
You're right. Anticoagulation certainly has a role. I think we're coming to the end of the session here. It's over to you, Dr. Asad, for concluding remarks by Professor Altaf.
Thank you. Thank you very much, Bushra. Since we are having a series of sessions, if there are any questions are left, so we can take them later. Our senior most panelist is Professor Altaf Alam. I'll go to him for his comments.
Thank you, Asad. Thank you, Adeel Bhai, and all my learned panelists. It was a wonderful experience. I also thank the participants for their active participation. There were many questions asked, and we tried to answer as many as we could. And Adeel Bhai has also taken up many questions later. So nothing gives me more pleasure than listening to a learned speaker and in the company of some learned people like Javed Iqbal Farooqi and Dr. Zishan. Thank you very much, and over to you, Asad, for your concluding remarks. Thank you.
Thanks a lot, Dr. Altaf. Once again, I would like to thank Professor Adeel Bhatt, our worthy panelist, our ECHO team, who's working very hard these days, and hats off to them. Kiran, Dr. Amna, Uzair, Haris, Salman. They've been working well. We have a new addition, Adnan from Karachi, who is now working behind the scenes, and they are working very hard. Usman Waheed of Ferozans has been very supportive. Thank you very much, Usman. Our Parsa Trust, who has been a tremendous support, and they have been with us for all the time. And Dr. Adeel Bhatt has worked very hard to get this collaboration with American College of Physicians. I'm sure this is going to make a lot of difference to the quality of education and our Zoom sessions with Project ECHO. As I told you, our next ACP session will be on 29th with Professor Adeel and Sanjeev Arora, because it is in connection with World Hepatitis Day. So no more COVID for a change. So we'll be talking about a virus which we can treat and which we can treat very well. And another session with our Parsa HealthNet ECHO Pakistan is on Sunday, which is 26th, and Professor Bilal Hamid will be talking on viral hepatitis in COVID epidemics. Bilal Hamid is well known to you. He's an authority on viral hepatitis, and he'll be joining from San Francisco. So Allah Hafiz, I'll thank all the participants at this time, and when there is a Zoom attack in Pakistan. So thank you very much, everybody. Allah Hafiz from Parsa HealthNet ECHO Pakistan. Till we meet next time.
Thank you, everyone. Assalamu alaikum.
Assalamu alaikum.